Thank you, Chairperson. Good afternoon. So my job is to tell you about the identification of a worsening heart failure, and probably will get some time to tell you the recent breakthroughs. This is a very important concept nowadays because one of the commonest cause of admission in most of the hospital is heart failure. Just to tell you this important slide, this is a very recent publication, although the data from USA. Over last few decades, you can see in this chart that after 2011, the mortality due to heart failure is rising. Despite good advancement for foundational or fifth foundational therapies, the mortality is not going down, it is up. We'll discuss why it is so. So coming back to the topic. So once we diagnose a case of a worsening heart failure, what are the important concepts? There has to be the worsening in the signs and symptoms of the heart failure because that is a sine qua non. It has to be a case of established congestive heart failure, and there has to be a strong medically recommended therapies in a proper doses. And that should also include not only the hospitalization but escalation of the therapy. So these four components, if they are present, we call it a worsening heart failure. And every year we see some refashioning of this statement because of the fewer molecules which are coming to the horizon. It is also a known fact that if there is this conglomeration of the finding, once we are labeling a patient to be in hospital or upgradation of the diuretic therapy, the prognosis is going bad and bad. So what we call, once you are worsened, it begets another worsening, and naturally mortality is going to be much, much more. So what is the outpatient worsening? This is important target because we see daily patients and none of the heart failures are really stable. Either they are controlled or they are uncontrolled. So just like in oncology, either they are in remission or they have an active malignancy. So similar concept to the cardiologist. So if we have to escalate the therapy, particularly the intravenous diuretics, and nowadays it is to the oral diuretics, this is one of the important concept in worsening heart failure. Because if you land up in hospital, there is no doubt it is a worsening heart failure. So the consensus statement, this is from the European, it includes and what it doesn't include. What is important, exclusion is new onset of heart failure is not a worsening heart failure. So first time you have encountered a patient with a systemic or pulmonary congestion with a structural or functional abnormality in the heart, this is not a worsening heart failure. So you have to exclude that. So in a well-defined cases of heart failure, we are silent. I am not saying whether this is reduced or preserved. So established heart failure on a therapy, if there is a worsening, this is worsening heart failure. Although we do not have much data about preserved EF, most of the data and the treatment is for reduced ejection fraction heart failure. The site of care is also not that important because initially it was only the hospitalization, and nowadays it is evolving from IV furosemide or IV other diuretics to oral escalation of diuretic will also be a congestive heart failure. So this concept is important because the mortality keeps on increasing once you have a number of factors if they are increasing from 1 year 10-12% mortality to 40% mortality if you have say 2 or 3 hospitalization within a year. So getting to the hospital was subjective because it depends in which part of the world you are practicing, in the rural setting, metros, in the corporate hospital. So this hospitalization is very subjective. So you have to take also that into account, whether you are reimbursed or you are on a salaried basis. There are so many things for getting a patient in hospital. So hospitalization decisions are mostly subjective unless the patient is in a really bad shape. So despite these understanding, we have to know how we can prevent it. And if you can't prevent the worsening, if you get such patients, you have to tailor your therapy of the heart failure in such fashion. Now, intensification of diuretic, this is very important concept. I keep on saying patients on 4 pillars of therapy without any diuretics. That is one of the most important cause of worsening of heart failure. So the assessment of a systemic congestion, assessment of pulmonary congestion is really important. And we are seeing 40, 50 patients, not 6 to 7 patients as our Western counterpart. So probably we need some sort of a help on that front. So if you do a proper assessment, need of the diuretics will be there. So if they are not on board, you really can't label them as a worsening heart failure. And how do we treat case of heart failure with diuretic? I'll recommend one of the good publication is enact heart failure. This is for the internist. If you see the protocol, how do you double the dose, whether you give a continuous infusion or a bolus, there is a way. Do you measure urinary sodium to see the effectiveness of your diuretic therapies? There is a way to do. So enact heart failure is one of the important protocol, at least for the internal medicine or even cardiologists. So we have learned about the 4 foundational therapy over last 4 years, and it has been shown that if most of the patients are on at least 50% of the doses of a 4 foundational therapy, you get the better outcome. Do we get much more importance if you are unable to reach 100% of the target dose? There is a question mark, but we'll come to the strong heart failure data. I always say try to achieve the maximum target dose. If not possible, try to reach at least 50% of the target dose of 4 foundational therapy. Probably will get similar result. So worsening heart failure represents an highest unmet need, because if you look at the trial, whether this is a paradigm or DAPA heart failure, or for that matter Victoria, the placebo control arm has got very high event rates. So look at the DAPA heart failure. Event rate in the placebo arm was, I think, 14%. Yeah. So in this, this is another data from a declare event. Look at the control arm. Your event rate is 19.5%. So these are the newer publications. So whatever you do, quadruple therapy or quintuple therapy, event rates in control arm is somewhere between the range of 15 or 20%. And all these data are not more than 2 years at best. So there is a lot of unmet need, and we keep on evolving. So apart from the 4 foundational therapy, another pathway apart from working on the neurohormonal axis, that is the sympathetic or RAS, or working on the SGLT2, or there is other activation models, and one of them is the cyclic GMP pathway. And Victoria trial is one of the important trial which has shown that even in sicker patient, if you add this molecule, you get the benefit. The inclusion criteria was important. In this they took less than 45%. I don't know why. Nowadays definition is 40%. And they have to have either heart failure hospitalization therapy, heart failure hospitalization last 6 months, or there is escalation of diuretic in last 3 months, and NT-proBNP has to be high. Then they were given 2.5, 5 milligram and 10 milligram vericiguat, and were followed up. And what it showed, there was a 10% reduction in the relative risk reduction. And although the mortality benefit was not that great, but there were certain good pointers. So the worsening heart failure annualized risk reduction is 4.2% with NNT of 24. So this is the one of the addition on 4 foundational therapies. If you meet the criteria of worsening heart failure, your event rates will still go down. And mind you, these are the very sick patients, unlike all other trials for 4 foundational therapies. Like mean NT-proBNP in this trial was 2800, unlike 14 or 1500 in other foundational therapies. You can see in this chart, Paradigm was 1600, whereas in Galactic was around 1900. But look at the Victoria trial, it was 2816. So these patients were really sick patients, and still you could achieve a annualized absolute risk reduction of 4.2%. So still you are getting a benefit, although the p-value was not that great, but it did make a very important impact. So what is the current scenario? If you are unable to give these medications, particularly because of the EGFR issues, because of the potassium levels, because of the very borderline blood pressure, so it comes to our rescue. And there have been a publication known as the P data set from the Germany, that if you add this molecule, it helps you to bring ARNI on board in a good number of patients. So these sick patients, very lowest blood pressure, creatinine on the higher side, potassium on the higher side, we are unable to give RAS blockade ARNI in particular. So if you give them very Sigwart along with beta blockade, most of these patients will recover in coming months, then it will pave the way for the introduction of MRAs and RAS blockade ARNI in particular. Regarding the doses, this does not cause much of the hypotension. The reported drop in systolic blood pressure is only 2 to 3 millimeter. So in fact, there is nowadays newer studies, probably you can start with 5 milligram, but the dictum is to start with 2.5 and go on increasing to 5 milligram and 10 milligram once daily. And we can give it up to a EGFR of 15, not much effect on potassium. So I was alluding to this slide. If you start with the smaller doses of the all 4 foundational therapies, you get the best result, rather than bringing up the dose of one therapy to a maximum, then keep on adding other foundational pillars. Nowadays, we are doing smaller doses, all the 4 drugs, if there is no absolute contraindication. And if there is any absolute contraindication, probably we'll chip with these alternate pathways of cyclic ZMP. So Vericiguat is probably one of the 5th pillar if you are already on 4 foundational therapies. Just to remind you that when this trial was done, SGLT2 inhibitors were not on board. Only 2% patients got SGLT2 in Victoria trial. So we don't know if someone has to do a trial today, how the result will be. But if you give SGLT2, it also, like Vericiguat, paves the way to introduce other molecules, particularly hyperkalemia is much less. In fact, potassium is on the lower side if you give SGLT2. So all said and done, we are always trying to add other pillars so that these unmet needs of 14%, 15% bad outcome can be ameliorated. And the iron therapy in heart failure, even without anemia, is important concept. Addition of alternative pathway activation, particularly the cyclic GMP activation, is another avenue, particularly for the worsening heart failure. Whether it will come in a stable, so-called stable heart failure without worsening, I think the time will tell, and we are waiting for publication of that data set. So unless that is published, nowadays role of Vericiguat or cyclic GMP modulation will be in fashion, particularly if you can prove that my patient of heart failure is having worsening heart failure. I'm not sure whether what will the data in heart failure preserved EF. That is the different ball game. Coming back to my first slide, why the mortality is increasing after 2011 is probably because of the more prevalence of the obesity, because of the more prevalence of heart failure preserved EF, which does not have much of the treatment apart from the diuretics and SGLT2 inhibitor, is the cause of increase in mortality despite the quadruple or quintuple therapy. So I end my presentation here. Thank you for the patience hearing.